Thank you very much. I express my profound gratitude for the gracious opportunities accorded to me to deliver this present. And today I present about anti-NMDR encephalitis in Vietnamese patients. An updated report of clinical features, laboratory investigations, prognostic factor, and outcome. First, I want to talk about some main points about overview of anti-NMDR encephalitis. As you know, autoimmune encephalitis occur as a result of brain-specific immune response with or without cancer associations. Anti-NMDA is most common in autoimmune encephalitis, characterized by complex neuropsychiatric features and the presence of the IgG antibody against the NR1 subunits of NMDA receptor in CNS. The disease was firstly recognized in 2005 by Vietnamese, and 2 years later, autoantigens were discovered by Denmark. Next is about epidemic information. You can see here in the foreground. The more of autoimmune encephalitis have the antibody negative. Only under 30% situations has a positive results, in which NMDR encephalitis accounted for high risk, about 80%. Only, hello. Other results in California shows that appearance NMDA is a higher, many times higher than virus encephalitis. Sorry. This relationship between the age, gender, and the proportion of the disease, as you can see, obesity relations. Obesity relation for female population with ratios female to male were 4 to 1. The most common age is from 18 to 23 years old. In patient outcome, we use MIS score to assess patient outcomes. A good outcome will defined when the MIS is less than or equal to 2 points, vice versa. One thing I want to emphasize is the most common has a good outcome is being treated in the first acute stage. Anytime during the first 24 months of follow-up, about 18% achieve a good outcome. However, the prevalence of relapse is still at high levels. About 12% of patients have relapsed within 2 years. Risk factor can be listed as duration of the disease more than 12 months and duration of first-line immunotherapy less than 3 months after the first onset. Otherwise, abnormal MRIs and inquiry intracranial pressures and even tumor not detected are also risk factors. Among triggers of the disease of ovarian teratoma and herpes simplex encephalitis are likely the most concerns. This picture shows the owner of teratomas. The first that is the owner of teratomas contain neurotissues, which also why teratoma is set as one of the disease triggers. The graph shows first state of clinical features accompanied with neurology antenations. First state includes vitalized problem and psychiatric symptoms, neurologic communication, and the last prolonged deficit, in which the worst degree level of consciousness is phase 3. Accompanied by clinical feature are laboratory investigations. Brain MRI is unremarkable in the 15% of patients as picture as reason can be seen abnormal hippocampus, right frontal lobes, middle cerebellar peduncles, and temporal lobes and insurers. Typically, mild or transient, often accompanied by subtle contract enhancement in the affected areas or the meninges. Remains normal or seminal chances by the severity and duration of symptoms. In initial durations, 18% of results was found CF abnormals, includes moderate lymphocytic polyocytosis, slightly increased protein concentrations, and sometimes normal, sometimes it's normal. CF specific oligoclonal in 60% of patients. You know, most of patients show intracellular synthesis of NMDA antibodies. Moreover, NMDA antibody in CF is a more disease specific than serum. Also, most of patients show abnormal EEGs, but it's not specific. There are some EEG patterns such as diffuse slowings, electrography seizures, diffuse excess beta activities, generalized rhythmic delta activities, and the last, this extreme delta branch, which associated poor outcome in some results and in some results. According to the Denmark and Graf standards, we have identified diagnosis and probable diagnosis as table below. There are some disorder which includes when diagnosing MRIs, antibodies, antibody NI receptor encephalitis. According to the scannings, with patient with anti-N-methyl-D-aspartate, with scanning, we classify our patient into two groups: tumor and not tumors. Each subgroups have a different treatment regimens, like diaphragms that is showing here. And then I talk about my studies. This decorative observational study was conducted at Neurological Center of Phan hospitals from January 1st, 2019 to August 13, 2022. By convenience sampling methods, 15 patients were recruited. The first objective of our study was to decrease the clinical feature and laboratory investigations of Anti-N-methyl-D-aspartate. And the second one was to analyze some prognostic factors associated with this condition. In our research, we collected some information of expression about general characteristics, clinical future laboratory investigations, and relying by MIS scores. We in discharge, we classify patients into two groups, good and poor outcomes, and then analyze some prognostic factors. Now I will give attention to the result of our research. The first is about general characteristics. The female to male ratio was over 2 times. The mean age of the patient nearly 32 years old, and the most common average was 18 to 23 years old. Psychiatric symptoms and neurological symptoms are two main in clinical symptoms. The mode of expression appearance with both in general psychiatric symptoms accounted for 19% of the all cases. This finding is the same line with other previous. research. The psychiatric symptoms in patients with anti-MDR and encephalitis are highly diverse and often present with multiple symptoms. We observe that the most common of psychiatric symptoms is cognitive dysfunctions, occurring in the 74%. In our studies, 94% investigators exhibited neurological symptoms. The most common neurological symptoms were decrease of level of consciousness, observed in 18% of cases. This result promotes done mouse finding in 2008. In other hands, studies found that seizure was the most common as a neurological symptom. About laboratory investigations, we witnessed 74% of patients have increased white blood cells. High increased white blood cells was seen in 18% of patients, and mid increase was seen 15%. It increased protein levels in CSF was observed in 16% of patients. In total, 15 patients, 8 of them has abnormal MRIs, accounts for 16%. Unlike MRIs, most patients show EEG abnormalities consistent with global results. Most of patients was not reported tumor, and in scale detected tumor, they was mostly ovarian telatomas. In our study, most patients received initial treatments in regular hospital was primarily using corticosteroids with or without plasma exchange, and rituximab was commonly used as a second-line immunotherapy. Our findings differ from some global practice, such as use of corticosteroids with IVIG together, which may be attributed to limited availabilities and cost of IVIG in our hospitals. The main outcome of discharge were primarily morbid and mild function deficits. Since we assess the treatment outcome at the time of patient discharge, and the reason differ from Xinhua studies. Reasons of differences could be our patient was adults in serious condition, while patients of the Xinhua were children who were less severe than ours. The change of the MRS at hospital admission and with discharge was showing here. You can note that the change better appearance after a treatment. The range of low MRS score enlarges, and it also the higher range of the MRS narrows. In patient outcome, we classify patients into two groups based on the treatments. At discharge, 24 patients with good outcome and 26 patients with poor outcome. Then analyze the difference between the factors. In terms of common characteristics, there were statistically significant differences observed between the two groups. Is gender and the MRS score admissions. Statistically significant difference was observed between the two groups in terms of psychiatric symptoms, specifically in behavioral disorders, as well as in cognitive dysfunction. There was statistically significant difference between the good outcome and poor outcome groups in the term of neurological signs, such as decrease of level of consciousness, movement disorders, and speech dysfunctions. The last autonomic dysfunction. Unlike clinical features, there was no statistically significant difference in any of the laboratory investigation between the two groups. After analyzing univariate on the factor has statistically significant differences, we found the factor related to poor outcome includes genders, behaviors, cognitive dysfunctions, decrease of level of consciousness, movement disorders, speech dysfunctions, autonomic dysfunction, and the last MRI score in hospital admission. After conducting multiple various analyses, we identified only two independent factors that was significant associated with poor outcomes, include males and MRI score in hospital admission. Includes below as characteristics of patients with ASEAN encephalitis in Vietnam. The female to male ratio was over 2 times. The meanness is 22 years old, and the most common age groups affects in the young people between 18 to 23 years old. The most common problem is headache. Psychiatric symptoms are present in 90% of cases, with cognitive dysfunction being is the most common. Among neurological symptoms, decreased consciousness is the most frequencies. 14% of patients detected tumors, as all of them was ovarian teratoma. CSF analyze typically show a mild increase in leukocyte counts. Brain MRI is finding so no abnormalities in the 84% of patients. EEG abnormalities are observed in the 72% of patients, and with 42% so data brass waste. In patient outcomes, the good outcome and poor outcome is similar, nearly 15%. Our study identifies to the poor outcome factors, which are initial MRI score and genders. There are some limitations in our studies. Protocols are still not standardized, and follow-up periods is relative short. So we plan to design a new study at the Neurology Center of my hospital to assess the limitation with the diagrams. Currently, we have enrolled 20 patients in 2022. We will report the study finding upon the communication of results. And this is the end of my presentations. Thanks for your attention.